Today I am talking about role of MIS in revision spine surgery. I was trained with Dr. Kulkarni from Bombay Hospital and also at Singapore General Hospital, where I learned minimally invasive spine surgery and anterior X-sleeve procedure. Okay, revision surgery is scary for patient as well as surgeon. But why it is scary? For a surgeon, it is scary because the culprit factor, which is a fibrosis. Due to fibrosis, the scar tissue, the complication rate is very high in revision surgeries compared to primary surgery. The most common complications are infection, CSF leak, nerve injury, and bleeding. These are due to when we enter in the fibrosis while doing open revision surgery, all these things can happen. So that's why we have to consider revision MIS surgeries in such cases. So why MIS revision surgery? Why not open? Okay, don't you think you are compromising on a decompression in already operated failed back patient? And do you think that the symptoms will resolve completely? What if it doesn't resolve completely? These are the questions which come in the mind of patient as well as surgeon. So for this, we have to go and see the reason for the revision. So generally in case of a operated spine case, the revision surgery is needed in these indications. First is instability. When the previously patient underwent surgery, there may be some injury to the facet joint, which leads to the instability in these kind of patient. Or there can be a recurrent canal stenosis. The central canal stenosis is very less likely because there is a significant amount of space created by a surgeon posteriorly by doing complete laminectomy. One of the common reasons for a revision in case of spine is recurrent herniated nucleus pulposus. First time we may try a revision discectomy, but sometimes when the piece of disc is in the foramen or at difficult location, we have to consider a fusion in such cases. Okay, then the foraminal stenosis caused by decrease in a height. So over a period of time, the operated disc gets degenerated, more and more degenerated, and the foramens get narrowed. In that situation, we have to consider a revision spine surgery. Then why MIS in revision cases? Because we enter through virgin territory in cases of MIS TLIF or a MIS procedure. Means we don't go through the fibrosis, we directly land on a facet joint and we avoid entering in fibrosis, which leads to less chances of bleeding because less handling of a fibrotic tissue, less chances of infection because we are not cutting the muscles, we are going through muscle splitting incision, which is located laterally, not through the previous incision. Less chance of nerve injury because the and CSF leak, because when you enter from the same incision, because of fibrosis, we cannot identify the neural structure very easily. Okay, so we tend to go to lateral side, we tend to go to normal bone, and then from there we go to the center. That means again we are damaging more soft tissue in case of a open surgery. Okay, and other advantage of MIS everyone knows, a less hospital stay, early mobilization, and less pain in case of MIS. Okay, today I'm going to share one of my case, a 70-year-old female who was operated with a laminectomy discectomy at L2 L3 level previously, presented with severe back pain, left more than right lower limb radiculopathy, significant claudication, tingling numbness in left lower limb, but her neurology was normal. There was a significant tenderness over the dorsolumbar junction and at the operative site. So, and all her blood investigations were normal, including ESR and CRP. So we did this MRI. So first thing we looked at was the D12 fracture, which is easily visible. There is an osteoporotic fracture at D12 level. And you can see in the left side of the foramen, there is a this herniated fragment of disc, which is compressing on the nerve. Then, and along with that, there is a foraminal stenosis at L2, L3 level, which was previously operated. So this is her axial cuts, where you can see at this L2-3, you can see over here, the piece of disc was pressing on the left-sided L3 traversing nerve root. Okay, and this is a scar tissue which was posteriorly. So you can appreciate scar tissue very well in this region where their previous surgery was done. So this was that patient's CT scan, which was showing that a significant amount of laminectomy defect on the posterior aspect of the back. Okay, so and this is her axial images where you can see the laminectomy defect. You can see the facet joint arthritis, arthropathy, and the laminectomy means luckily the facet joints were not significantly resected, but because of the foraminal narrowing, we planned to do a MIS TLIF in this case. Okay, so this is what we did in that patient. Sometimes means I use tubular dilators also, but in case of revision surgery, we tend to prefer a macular retractor because it allows bit wider separation, wider distraction. We means if you use a tubular dilator, you land up on the bone, but you cannot use nibblers. I prefer to use nibblers because there is a very less amount of bone left in case of a revision spine surgery. Okay, so here we directly landed on the facet joint. So we dissected the facet joint. Then what we have to do is we have to dissect the lateral aspect of the laminectomy defect, and we have to release the soft tissue from the inferior facet, means the bone which is left after laminectomy, the inferior facet of superior vertebra. So with the help of curate, we have released the soft tissue and fibrosis from the undersurface of the inferior facet. Okay, means by identifying the laminectomy defect. Then in this case we use a osteotome. We don't use osteotome like means first surgery. We use a osteotome between the superior facet and inferior facet in order to get some amount of bone for the fusion, which we can use for the fusion. So we use a osteotome in such a way that there is space between the laminectomy defect and the superior facet. So we just remove the lateral part of a inferior facet with the help of osteotome, nibblers, and disc forceps. Because of this, we get a significant amount of bone graft even in case of a revision surgeries. Okay, so we remove these pieces with the help of Kerrison punch and disc forceps. And luckily, advantage of using macular retractor is we can use a nibbler, which we cannot use through the tubular dilators. And if I'm not planning to do over the top decompression, I rarely use tubular dilators in case of a revision MIS surgeries. So after this, now we took out the inferior facet of a upper vertebra. Now we have to take out the superior facet of the lower vertebra. By doing means for that we have to identify inferior means medial aspect of the superior facet, and we have to release the soft tissue and fibrosis from the undersurface of the superior facet of the lower vertebra. So we release the fibrotic tissue and soft tissue. Till this point, we haven't exposed any neural structure, because if we expose a neural structure at this point, there is chance of injury to the neural structure. So we removed the facet joint using Kerrison punches. The important thing here is this Macanab bleeder, which causes bleeding in this case. So we have to coagulate this Macanab bleeder very carefully, which is located on the lateral aspect of the facet joint using bipolar. Okay. Then after the resection of a superior facet, we directly land up on the disc. Okay, so at this point we have to identify the disc. We have to identify the neural structure in order to avoid injury to the neural structure. Once you identify the disc, then I looked for the piece which was there in the MRI in a lateral recess, which was compressing on the traversing L3 nerve root. Okay, so this is how we remove the superior facet. See, the part of superior facet was still remaining, so we used a Kerrison ronger to take out that part of superior facet. Okay, then see, from here we have to identify this gap. We have to put a Kerrison properly, then we can remove the superior facet. Once you remove the superior facet, this whole part is a disc. From that disc, we have to remove the herniated part of the disc first before doing anything. So see, with the help of Watson chain probe, with the help of Penfield, and with the help of nerve hook, carefully without damaging the neural structure, we have to remove the piece of the disc pieces of the disc which are in the canal first before entering in the disc space. So now means with the help of this nerve hook, we fiddle and we fiddled and we took out that piece which was compressing. The piece was significant. You have to see that whether the piece is significant or not, because sometimes we tend to under decompress, that we think that piece is out, but see, this is how this big piece was there in that foramen. Okay, means in that lateral recess which was compressing on the nerve. Then we retract the nerve with the help of nerve root retractor, and then typical like other MIS procedure, we use a curette, we use a shaver to enter the disc space, we clear the disc space, we remove the disc material, and then we put a cage along with a bone graft for the fusion purpose. Okay. So this is how it looks when we use a Macaulay retractor. Actually, when you use the tubular dilator, the scenario is different. But if you don't want to go, there is no need to go on opposite side for the decompression, over the top decompression, this is a very good retractor. This is versatile, where you can use a nibbler also. Okay, this is a lateral picture and AP view after putting a cage. This is final X-ray picture where we were able to put a good means we were able to give a good lordosis with the help of cage, and we compress posteriorly in order to achieve the lordosis. So why MIS in revision cases? This was the paper where I worked with Dr. Kulkarni. Means I was a part of few cases of this paper where we did a MIS surgeries. Initially, I used to think that we can do a open surgery and we can do a thorough decompression. But I have seen a significant number of revision cases with Dr. Kulkarni, and after that, my view for a MIS revision surgery is changed. Okay, the another paper was published in 2020 by Mansi et al., which has shown that significant amount of significant betterment with a revision surgeries if you use a MIS technique. Okay, so these are the two papers which are recently published in order to prove that MIS in revision surgery is really helpful. So take home message: MIS is very effective, safe and viable option for revision spine surgery. Other things are same, like there is less complication with MIS, early mobilization, less hospital stay in a patient where we do a MIS surgeries. Okay, thank you.